Good evening, everybody. I'm Dr. Sumathi Muralidhar. I'm Professor Consultant, Microbiologist at the Apex Regional STD Center and the State Reference Laboratory for HIV. I bring you greetings from the Vardhaman Mahavir Medical College and Safdarjung Hospital in New Delhi. At the outset, I wish to express my sincere thanks to Dr. Neeraj Jain for inviting me to speak at this important forum. Today, I will share with you some information on quality assurance in microbiology. Now, I have planned my talk this way. Firstly, a few words introducing the topic, then some definitions of important terms in quality. And I will then speak about quality assurance in laboratories in general, because it applies to microbiology laboratories also. And then some aspects of quality assurance that are exclusive to microbiology laboratories. And finally, I can share some experience to make things clear and help you on some practical aspects, especially with accreditation. Nowadays, everybody is stressing on accreditation in laboratories. Yeah. So for a start, let us look at the laboratory scenario in India. There are more than 1 lakh medical laboratories in India, of which more than 80% of them are small labs, with only about 18% medium labs and 2% large laboratories. And for the record, it's only the large and medium-sized laboratories that get accredited. So what happens to all the small labs? They eventually either they merge with the larger labs, or they become collection centers, or some of them may even close down. Or many a time we see that these laboratories, they continue to provide substandard services. So why is there no trust in laboratories such as these? That is because they are not good. So what do we mean by good and bad? How do we conclude that the laboratory is good or bad or best? So when do we accept a laboratory as being the best? Can 99% level of quality be considered as best? Can we accept a 1% failure or error rate as far as laboratories are concerned? I want you to remember here that the medical profession, just like in the aviation industry, we cannot accept even a 1% error or failure rate, which could be disastrous. So you see, the performance standards required in medical profession and laboratories is very high. In this, we refer to what is called as the 6 Sigma standard. This is a concept where the error rate is very, very minimal, almost nil. So when you say a laboratory has a success rate of 99.9997, that is the 6 Sigma, then you say that it's almost perfect. Okay. This concept actually began initially in the motor industry, that is in the automobile industry, where one of the persons who was working with the Motorola company, he made the calculations and decided that this 6 Sigma, that is Sigma is the Greek letter which denotes the standard deviation. So when the standard deviation is at the 6th level, so that means the chance of error is very, very minimal. It's only about 3.4 per million incidents. That means if you do a thing 1 million times, the chance of making an error is only 3.4 times, which is almost negligible or nil. So this is what we have to aim at even in the laboratory. Now, laboratory errors, they cost us not just in terms of money, but more importantly, in terms of the time, the effort, and the patient outcomes. So let us see why laboratory errors occur. There are many, many causes, as I have mentioned here, but all of them can be brought down to just one important point, which is poor quality management. It could be because of poor workload management. It could be because of the time pressures, or the staff may be insufficient or not trained or not competent. It could be due to poor competency and poor quality control assessment, or due to non-validated tests. Any of the causes can be there. But overall, what we can bundle it into one point, that is poor quality management. So now we come to the important question of what is quality? There have been many stalwarts who have given us a very good understanding of what quality is all about. I have here mentioned some of the names and shown the faces over here. They have all been involved in what we know as quality today. These are the people who have introduced these terms and made a lot of progress in this regard. So what is quality? In layman terms, it can be defined in many ways. We can say quality is anything that is of a high standard or level or a degree of excellence. Or we can say that when whatever we expect, if we get what we expect, that is supposed to be good quality. So whatever it is, WHO has given us a definition, and they say that quality is a service or substance that meets predetermined requirements of the users. So why is quality important in a laboratory? We can infer this from a study which has shown that 70% of clinical medicine decision making is dependent on the laboratory results. So that's how important our laboratories are. The total laboratory quality program includes several interrelated terms. For example, the quality control, quality assurance, continuous quality improvement, performance improvement, and total quality management. So each of these is a subset of the other. The overarching term is total quality management, and under that you have the continuous quality improvement, the quality assurance, and the quality control. So let us just learn a little bit about these terms. Quality control refers to all the internal activities which ensure that your test is performed correctly and your result is accurate. That is, the tools that you use, how you do the test, who does the test, and what are the the conditions under which you perform your test, whether you're using controls or not. So everything that makes your test successful is coming under the term quality control. So for example, when you put up controls, you perform the diagnostic procedure as per the standard operating procedures. So that means you are doing it as your quality control is good. So when we say quality assurance, this is associated with the external activities that ensure a positive patient outcome. That is the entire system. So you can say that quality control is a subset of quality assurance. Quality assurance measures what a laboratory can do to improve reliability. It's all about being right. That is the right patient, the right sample, the right test being done, the right procedure being used, the right report being given out to the right person, and so on. So it's all about being right. Now, continuous quality improvement, this emphasizes not only making mistakes and not only performing the tests, but not making any mistakes in the first place. So when you are getting to perfection, when you perform very efficiently, then you do not make mistakes. And that is the stage we have to reach. So this is ensured by continuous quality improvement. So you have to continuously improve your work so that there are no mistakes. And performance improvement is, in other words, continuous quality control improvement is performance improvement. It advocates continuous training to guard against having to correct deficiencies. So what you aim at is you do not make mistakes, therefore your performance is perfect. So if you don't want to make mistakes, how do you go about doing that? That is by continuous quality improvement. That means you have to have systems in place such that you do not make mistakes in the first place. So this entire process comes under total quality management. That is from start to finish. Yeah. So coming to the laboratory's performance assessments, the activity can be internal or external. Your quality control can be internal or external. So internal quality control includes whatever you do within your institution or within your laboratory. For example, quality indicators. You set up quality indicators so that you improve your performance, or performing internal audits to find out what are the things that are going wrong in your laboratory, and management review meetings. So when you do your internal audits, the review meetings, all this is part of your internal quality control. So what about the external quality control? This refers to all the activities which will involve external agencies, such as your PT, EQUAS. PT is proficiency testing and EQUAS is external quality assurance schemes. So when you participate in an external quality assurance scheme, that means an external institution or person or somebody is auditing your activity. And other external quality assurance measures are inspection by external bodies or accreditation processes. So these are all the external activities. Now let us see what are the factors that influence your internal quality. So this is the first step to improving the quality in your laboratory. You have to know what are the factors that influence the quality of your lab. There are many factors within the laboratory and outside of the laboratory. Those that are within the laboratory, these factors are directly under your control. So you can control these. For example, you receive the samples in a proper way, you process them appropriately, you perform the test procedures appropriately, and you generate the results appropriately. So if you do all of these properly, then you can control the internal quality of your laboratory. But then there are certain aspects, the external aspects, which are not really under your control. For example, how the sample is collected, is it from the right patient, is the requisition form filled up, the sample collection, handling, transport, till the sample comes into your laboratory. There are certain aspects which are very important. So these also have to be taken into consideration. So not only the internal aspects within the laboratory, but also the outside the laboratory aspects. If you are able to control all of these, then your internal quality control will be perfect. So a few words about the external quality assurance. So this can be achieved by various methods by which the performance of the laboratory is assessed by external agencies. For example, the participation in various proficiency testing programs, the external quality control programs, which are organized by outside agencies. And here what happens is, the proficiency testing or EQUAS, when you sign up for these activities, an outside body will send you some blinded panels. And then you perform the test just as you are performing the routine tests in the laboratory. And once you perform the tests, you send them your results and they will give you a feedback. So if you perform very well and your scores are very good, that means you are performing well, the quality of your laboratory is good. So this is being endorsed by an external agency. So this is one of the best ways of improving the quality of your laboratory, that is by participating in the PT or proficiency testing procedures and the EQUAS procedures. The second method is a retesting or the rechecking EQUAS. So here what happens is, the tests which are already performed, so you send 20% of, some percentage of the positives or negatives, and you get it checked by an external agency. I'll give you an example. We perform this retesting EQUAS in our laboratory for the HIV activity. So what we do is, we are the state reference laboratory. So under us, we have 20 ICTCs, that is the integrated counseling and testing centers, which perform the HIV test. So every quarter, that means 4 times in a year, we perform this retesting EQUAS. So in the month of January, April, July, and October. So in these 4 months, the first week, whatever samples are collected by these laboratories, they send 20% of positive samples and 5% of negative samples. They send it to the lab above them, that is to the state reference laboratory, that is our lab. And we check it and give them a report saying it's correct or wrong, or if there's any discordance, we sort of inform them. So this is one way of checking. So if you cannot participate in a proficiency testing program, you can participate in a retesting program where you submit your positive and negative samples to another laboratory and they grade you for it and tell you whether it was correct or wrong. So this is another way of checking your quality. The third is inter-lab comparisons. That means you send some samples to another lab and the other lab sends samples to you and you compare each other's results. So again, we are participating in inter-lab comparison with AIIMS for our CD4 testing. So twice in a year, we send our samples to them, and then we get it cross-checked by them, and they do the same activity with us. So this is another way of checking, and the inter-lab comparisons, where another way of checking the quality of your laboratory. And then if you cannot participate in any of these, there is what is called as the split sampling, where the same sample is checked by a team of people, and then they all come to a consensus. So apart from this, the other way of assuring quality is on-site evaluations and audits. A very good example of this is the accreditation programs. Now, so a few words about the, just a moment. Yeah, what are the differences between external and internal quality control? So when you say internal quality control, it is a concurrent and continuous activity. That means the quality within your laboratory is ensured only when you continuously work at it. Okay. Whereas the external quality assurance is a retrospective or a periodic program. That is, you don't do it on an everyday basis. So whereas your IQC is an everyday activity, and this is performed by your laboratory staff, whereas the EQA is done by an independent outside agency. And the objective in case of an IQC is to release reliable results on a day-to-day basis. So as I told you, IQC is an everyday event, whereas EQA, this is for inter-laboratory compatibility, or if you want to get your lab accredited, so then you participate in these kind of activities. So there are many variables that can affect the quality of the results in a laboratory. So I have enumerated some of them here. Please remember, this is not an exhaustive list, but these are some of the important points one must take into account. For example, the personnel. The personnel in every laboratory, you have to have their educational backgrounds, their certifications, they should be trained, their competencies should be assessed. So all of these should be taken care of. And then the specimens, the condition of the specimens when they arrive at your laboratory. And of course, the IQCs, I've already told you a little bit in detail about this. The kits and reagents, the quality of your kits and reagents, they have to be checked, they have to be verified, the lots have to be validated and verified. So this is important about the kits and reagents, the expiry dates have to be checked. So all this has to be looked into. And for equipment, it's a very important activity again. The quality and status of your equipment, that is the installation qualification. There are certificates that are given by the firms, the installation qualification, the operational qualification, the performance qualification. So these are different activities. Installation is when they install the machine, they have installed it correctly. So then they give you a certification that it has been installed correctly, but you still don't know if it is operating correctly and if it's performing correctly. So once it is operational and performing correctly, the certification is given. And then routinely your annual maintenance contracts have to be, have to be confirmed with the firm. And your calibration processes should also be there regularly. It has to be done, whether it's annual or 6 monthly, whatever you're doing, that has to be properly done. And environmental conditions have to be checked, because in a laboratory, there are certain tests, especially in a microbiology laboratory, the temperature becomes very important. So you cannot have temperatures fluctuating and all that. So the air conditioning, the lighting, and all aspects, whether it is the restricted entry, all this have to be confirmed, all this have to be in place. That is the environmental conditions. Documentation and record keeping, they have to be perfect, because everything that you do has to be documented, and all the records have to be maintained in a very orderly fashion. And of course, participating and performance in the PT, EQUAS, ILC, as I just mentioned. And the results, the interpretation, the transcription, the reporting of the results, and the accuracy of the results. So this again, so all these are variables. That means they can go wrong. They are not constant, they are variable. That's why they can go wrong. So you have to pay attention to all of these. So, the working in a laboratory, let me just click on this slide. So to ease things up, we have this path of workflow in a laboratory. So the workflow in a laboratory can be divided into the pre-examination, the examination, and the post-examination phases. So these are also called as the pre-analytical, analytical, and post-analytical phases. So these are the factors which for convenience, we are dividing them. But then you have to pay attention to all these factors when you are taking into consideration the quality of the laboratory. So let's just take a look at the pre-analytical activities. It begins with the patient who comes with specific signs and symptoms, and when the clinician orders the relevant test. For example, when there is a case of fever or typhoid and fever, and when the clinician is suspecting typhoid, you should know when to order the test and what test to order. For example, if you're suspecting typhoid, you should order a blood culture if it is in the first week. If it is first week of fever, you have to order a blood culture and not a Vidal test. Whereas if it is a second week and beyond, then you have to order the Vidal test and not a blood culture. Because these aspects have to be known, because you have to have the correct sample and the correct test has to be performed for proper quality of, if you want good results. The next important aspect is the filling up of the TRF or the test request form. So all details have to be given so that the laboratory knows what exactly you are suspecting. Then follows the appropriate collection of specimen, the proper labeling, using of appropriate container, transporting of the proper in the proper temperature, the storing, and when necessary, under ideal conditions. So for example, CSF samples, they should never be refrigerated. If you are intending to send the CSF sample for a culture, then you should not be refrigerating it. So these are some of the factors, pre-analytical factors. That is, before the testing begins, you have to ensure that all these factors are taken care of. Only then the results will be appropriate. So moving to the analytical factors, that is the actual performing of the test. Here, again, a large number of factors are involved. The equipment used, are they calibrated? Are they under AMC or CMC? How about the quality of your reagents? Are controls being put up? Are the readings being taken properly? Are the methods used for testing, are they standardized tests? Have the methods been validated? And are the staff performing the test properly? Are they skillful? Are they qualified? Are they competent? And so on. So all of these come under the analytical factors. Now, talking about the post-analytical factors, this involves the reports and how it should be, how the reports have to be made, and whether they are accurate, and they also have to be generated in a timely manner as per the turnaround time decided upon. The report should be provided to the correct person, and the range of normal values should also be provided to the clinician, because ultimately we are all doing it for the clinician to give appropriate treatment, isn't it? And talking of post-analytical factors, please do not forget that specimen disposal and biomedical waste management is an important post-analytical activity. And all about this will be talked and told to you by Dr. Malini after me. So all in all, there is a philosophy in quality assurance program, a rule of thumb. It says anything that moves has to be trained. Anything that does not move should be calibrated. And whatever happens in the laboratory should be documented and put on record. If it is not documented, take it for granted that it never happened or it was never done. So that this is the rule of thumb that we follow in NABL and in other quality aspects, accreditation and all of that. Everything has to be on record. The documentation should be maintained properly, and the training, calibration. So it's about all of these, the quality. So with this, we have covered the general laboratory quality control and quality assurance aspects, which are relevant to the microbiology laboratory also. Although what I told so far was the general for general laboratories as well as the microbiology laboratories. Now let us focus specifically on quality assurance in the microbiology laboratory. Firstly, let's look at the role of a microbiology laboratory. Although making a diagnosis and helping the clinician start appropriate treatment is one of the important roles of the microbiology laboratory, this is not the only activity. It can serve many other purposes also, such as monitoring the treatment, detecting asymptomatic cases or multiple cases, which are often missed by the clinicians, and for contact tracing, for epidemiological aspects, for screening, medico-legal cases, for research. So for all of these, the microbiology laboratory is very useful. So that means the lab is very useful, microbiology laboratory, and the quality is very important. So how do we go about assuring the quality in a microbiology laboratory? So the laboratory can serve as a positive outcome in terms of reduced hospital stay, cost, and the turnaround time is also reduced, and initiation of timely and appropriate antibiotic treatment. So all of these are ensured if the quality of a microbiology laboratory is assured. So what makes the microbiology laboratory different from other laboratories? For a start, the kind of specimens received here are not uniform. For example, in biochemistry labs, mostly it may be blood or urine, but in a microbiology laboratory, it could be pus, it could be blood, urine, CSF, sputum, synovial fluid, or anything, depending on the site of infection and other factors. Also, a microbiology laboratory requires a separate space to carry out activities. Unlike maybe other laboratories where, in a section of the laboratory, in a part of it, you can perform in one corner some test and another corner another test. That is not possible in a microbiology laboratory because there are some activities which are incompatible. For example, if you are carrying out, performing culture of Mycobacterium tuberculosis, you cannot perform fungal cultures and other bacteriological tests in the same area or in the same section. A microbiology laboratory also requires separate areas for washing, sterilization, media preparation, and appropriate waste disposal facilities because we are dealing with highly infectious materials here. So one has to take care of all these aspects. So quality assurance in a microbiology laboratory should ensure quality control of the stains, and they should have sterility controls. They should use positive and negative controls for all the test procedures. We have to check and maintain the stability of the stocks and the control strains. So all of these have to be looked into, which are unique to a microbiology laboratory, unlike other laboratories like pathology and biochemistry and all of that. So I have here some exhaustive and busy slides on quality control processes for every stage in a microbiology laboratory. But I shall only stress on the important aspects. Here we see there are quality control procedures for filling up the TRF, guidelines for sample collection before starting the antibiotics. Remember, in a microbiology laboratory, if you are wanting to do cultures and all that, you have to collect the specimen before antibiotics are started. So once the patient is on antibiotics, there's no point in collecting samples for culture because you're not going to get any positive results. So, and also use of sterile containers and rejecting specimens that do not comply with the requirements. Again, the transportation of microbiological specimens to the laboratory has to be appropriate in terms of temperature, use of transport media, use of 3-tier transport container, etc. All test procedures should have well-defined SOPs which describe exactly what has to be done with the specimens. The staff should be well-trained and sometimes specifically trained for specific test procedures. For example, in our laboratory, we perform the CD4 count, and our lab is also the reference laboratory for gonococcus, for gonorrhea. So the technicians who are performing the gonococcal cultures, it's a very fastidious organism, so you need a lot of skill in isolating the gonococcus and performing the antimicrobial sensitivity testing and all that. So we have very skilled technicians who perform only this work. So not every technician does this test. So we have people who are specific for this activity. So also for CD4 count, we have technicians who perform only that test. So you can relegate, technicians for if it is a very highly specialized kind of work. For media, reagents, and stains, whether you buy them commercially or you prepare them in-house, the quality of these has to be assured with the use of control strains. For example, the ATCC control strains are available, the American type culture collection. So we can purchase them and use them as controls for all the tests. So before you perform any test, and when you use new media or when you're using your strains, you always have to use the ATCC control strains to check the quality of your media and your stains and other procedures. The appropriate reactions should be achieved to pass the lot of media or stains or reagents and to declare them fit for use. Here are some examples of biochemical tests which are performed in a microbiology laboratory for identification of bacteria. For each of these tests, there are specific ATCC control strains which are used and which give a positive or a negative result. Only when these tests are passed, then these biochemical tests can be used for identification of specific bacteria. So these are certain items which are unique to a microbiology laboratory. Now, quality control of equipment. This has been covered in a general section earlier, but just an emphasis here that all the equipment used in a microbiology laboratory, they should be qualified. That is, I spoke about the IQ, OQ, and PQ. They have to be validated and calibrated and maintained well by opting for annual maintenance contract or comprehensive maintenance contract. So all of these have to be looked into. It's more important for a microbiology laboratory. Talking specifically about stains used in microbiology laboratory, here again, there are control strains that are used to verify the positive and negative results. For example, if you're performing a gram stain, you can use the E. coli ATCC strain to confirm the gram negative bacilli. So if this E. coli ATCC strain is giving you gram negative results, that means your staining is correct. So also for gram positive cocci, you can use Staphylococcus aureus, which usually is used as a control strain for this to check for gram stain. Now, we now come to a very important role of the microbiology laboratory, and that is antimicrobial susceptibility testing, or AST. Earlier, we used to call this antibiotic sensitivity testing. Okay. So for this, there are way too many specifications and requirements to be met right from the start to the finish. For example, if you are performing the Kirby-Bohr disk diffusion method for antimicrobial sensitivity testing, all the parameters have to be checked. For example, the media you're using, the depth of the media, the size of the inoculum, the disk placement, the storage of the disks, the temperature of incubation, and so on. So every small step is important for you to get good results. So you see here again the results of inappropriate conditions for AST. Like you can see, if you have an acidic medium, this affects the zone sizes of certain antibiotics. And if you have an alkaline medium, it affects the zone sizes of certain other antibiotics. And if you add defibrinated blood, it decreases the activity of sulfonamides. So when you have a knowledge of all of these, you will understand how important it is to have the correct media for your antibiotic sensitivity testing. So this slide is just to impress upon you how exacting the requirements are for AST. That is the inoculum size, the timing of disc placement, the spacing of the discs on the media, the potency of the discs. All of these play a very important role in getting good results and reliable results. This diagram here very aptly describes the quality control, quality assurance, and quality management system. So all these, I told you earlier that they are subsets of each other. And in this diagram for antimicrobial susceptibility testing programs, this is very well explained over here. Quality control is performing the AST appropriately under ideal conditions, while quality assurance is a broader term involving the processing, analyzing, and reporting of the results. And quality management system is the overarching activity of all the related processes. So when you are practicing all of these, you get what is called as the total quality management. So moving on to yet another type of testing in a microbiology laboratory, which is very important, that is quality control in serological tests. Here again, quality control involves a well-prepared SOP. SOP is standard operating procedures. That means every procedure that you perform in the laboratory should have a manual, that is a SOPM, which is called standard operating procedure, has to be there, so that, you know, when new technicians come, they should know what to do, or even the technicians who are routinely doing it, if they have some doubts, they should be able to refer to the SOPs. So SOPs are very, very important. And you also have to use good quality serum, not serum which is lipemic or hemolyzed or anything. Sterile anti-sera have to be used, and everything has to be within the expiry date. Then you have to use positive and negative controls also. And new lots of serological test kits have to be verified. Okay, they have to be validated and verified, which is an important activity. So here are examples of some of the tests that require positive and negative controls. These are some serological tests which are commonly carried out, like the VDRL test, which is performed for the sexually transmitted disease, that is syphilis, the Vidal test, which is done for typhoid, and ASO titers, which that is anti-streptolysin O test. So these are some of the tests. This is just to show you that quality control is very important even in performing serological tests. Now for serological tests, it's important to record and evaluate the control values and to prepare the Levy-Jennings charts. I will not go into the details of how it is done. You know, you have to find out the standard deviations and then the coefficient of variation and all that. So ultimately, what is important here is that you have to check whether the procedure is in control or out of control. So for that, you make these charts. And if you are performing ELISAs and all these serological tests, then the Levy-Jennings charts become very important. You'll have to learn about it and perform the quality checks by using these charts. Now, quality control guidelines are also to be followed in reporting and in participating in PT-EQUAS and for referral of samples too. Yeah. Another important quality control procedure in the microbiology laboratory is to check for the sterilization procedures. So for this, to check whether your autoclaves are functioning properly and whether your sterilization is being performed properly, we have physical, chemical, and biological indicators. So the physical indicators, usually they only check whether the temperature was reached, whereas the biological indicators, they even tell you whether actual sterilization has happened. So the autoclaves and hot air ovens, for all of these, you can use them. And the items that are intended to be sterilized, you have to first make sure that the equipment is working properly. So there are some test procedures that are not to be done in a microbiology laboratory. This is just an example to tell you that the urine cultures are not to be done in patients on all antibiotics, because obviously it won't be of much use. And there is no point in performing a bacterial culture in specimens where the normal flora or commensal flora are there, such as mouth, bowel. So right from the time you choose your specimens, you have to think of quality assurance and quality control. So just to summarize here, this is an algorithm for quality assurance in microbiology. That is, you identify the right patient, order the relevant tests, collect appropriate specimens of good quality, label them appropriately, and transport them quickly to the laboratory in an unchanged state, proper accession in the laboratory, perform accurate and precise analysis, and document your report, document and send in your reports accurately and appropriately, and proper interpretation, and of course, timely action on the right patient. So this can be ensured only if you follow all of these in a proper manner. So with this, I come to the end of the quality assurance in microbiology. So finally, the last couple of slides. the last part, this is just some experience sharing just to help you in your journey towards microbiology laboratory accreditation. So I'm just sharing my experience. My first brush with quality assessment was in 2002 when I attended a few lectures on, all of where I just for the first time I heard about accreditation and what is NABL and all of that. And then in 2009, there was a team that came from NACO, and this was an external team that came, and that was our first external audit. And it was NACO's initiative to get all the HIV testing laboratories accredited by NABL. So they started this initiative. And us as an SRL, so they wanted to assess the SRL's compliance to the 12 quality system essentials. And needless to say that our performance was quite poor at that time. We got a 2-star rating status. So this truly was a wake-up call for our laboratory. And we were totally or partially deficient in many of the managerial and technical clauses of ISO 15189, which I have just enumerated them over here, but nothing to go into too many details. So you see, our performance was bad. We were deficient in many technical and quality aspects. So we were literally pushed to a corner. So our only option was to start the process, pull up our socks, and to get going and start the accreditation process. So we began planning, and with administrative support, we designed the various, designated the various posts, designed the various SOPs and the QSPs as per requirement, and we set our targets and priorities. The staff had to be motivated, which, every aspect is very important. So we started the process, and we performed quality checks at every step of the way. So we took into consideration the pre-examination procedures, the examination procedures, the post-examination procedures, what we have been doing wrong and how we can correct them. So we looked into all of these activities. So all the variables, whether they were pre-analytical, analytical, or post-analytical, we looked into all of them and we addressed them. And we also strengthened our PT EQAS by participating and performing well in all our tests. And all the tests in the scope of accreditation, we initiated the PT EQAS activities, and we started performing well. And then we started maintaining our records and documentation. Everything was strengthened. We took care of our equipment, got them calibrated, and the maintenance, AMC, CMC, all of that we got done. We looked into the training and competency assessment of all our staff members. We conducted our internal audit and the management review meeting, and then we applied for NABL accreditation as per ISO 15189, NABL 112 and all that. And in all of these, please remember that there are some soft skills also which you cannot ignore. So the soft skills, that is, you involve people, work as a team. All of this is very important because, quality in a laboratory and going in for accreditation can never, ever be an individual effort. It's always a team effort. So involve people and be open and transparent, be positive and constructive, stay focused. And one shouldn't be overcritical, and we have to be non-judgmental, non-aggressive, non-confrontational. So all of these we have to pay attention to, because the soft skills are usually forgotten when we start doing only what is required in a very practical way. So as for the cost, well, the accreditation is a costly affair, let me tell you, that is agreed. But the maintaining of equipment, reagents, participating in PT EQAS, applying for accreditation itself, all of these are very cost intensive, and they are costly. Yet the returns in terms of getting accredited and in being good as other laboratories elsewhere in the country, and the sense of achievement that you get, believe me, these are priceless. So it's well worth the effort. And my final word is that even if it seems like a mountain, it is well worth it, and you can surmount it, and ultimately you can do it. Because being, especially coming from a government institution where there are a lot of hiccups and problems, if we could do it, yeah, I'm sure everybody else can do it, because all it requires is good administrative support and the will, and the team effort. So this is my advice, and all that I had to say. Thank you very much for your attention.
And the biomedical waste management. Yep. Yeah. Okay, so it's the rules, guidelines, the biomedical waste rules 2016, 18, 19, and the CPCB guidelines 2018, 2020, 2021, and 2022. So if I say, I mean, what's the need of such big title? Because it's just to say that the rules and the guidelines, ever since they got notified in 2016, they have been certain amendments, certain revisions, and this is consequent to certain certain international documents our prime ministers and presidents, they have signed from time to time. And so we have, and if I talk of healthcare waste means it includes biomedical waste, it includes the plastic waste, then it has e-waste, it has hazardous waste, it has solid waste, and it has construction and demolition waste with it. And these rules and regulations, they are interrelated. I mean, if I say that how are biomedical waste rules going to be affected with the plastic waste management rules? So we know that plastic waste management rules got notified amendment also in 2021, then recently in 2021, January. They have important implications because initially the biomedical waste management bags, the disposal bags which we were using, they were of 15 microns. But now if you see, they are of it's 75 microns. And by next year, they are likely to get increased to 120 microns. So these have important ramifications with other rules also. So am I audible, sir? I hope there is no disturbance now. Yeah. So I will be touching on these rules, like, for example, the solid waste management rules, that is 2016. Everybody knows about Gila Kachra and Sukha Kachra. But if your hospital, it is more than 5,000 square meter in size, you need to have an on-site compost plant like Safdarjung Hospital has got. And if your hospital is generating more than 100 batteries, again, you need to be sending it through registered recyclers, because we all know that all the automated equipments in the labs, and we have various offices, we have wards, the computers are there, so the battery use is there. And even the CT scan machines, they also have automated equipment, then batteries are there. So we need to follow the battery rule also. And then we have hazardous, that is metals, heavy metals like mercury, cadmium, and lead. Now, lead waste, which is primarily produced in radiology department, the lead aprons, lead goggles, the shields, they need to be disposed of by an authorized recycler. So that is a take-home message. Then mercury, initially we were using the mercury dental amalgams, but recently they have been now replaced with the glass ionomer amalgam filling, which you need to dispose of in the yellow category waste. So if any dentist is there, and so what about the radioactive waste? You know, initially the automated equipment in the microbiology department, like the BACTEC and all, they were having the radioactive, I mean, indicators. One is colorimetric method and the other is radioactive method. So that was having an important implication because of the radioactive disposal of radioactive waste, you have that 10 times the half-life of the radioactive waste. You need to store them and then dispose them as per the normal biomedical waste management rules. It is to be considered as biomedical waste. And all the hospitals which are having the nuclear medicine or the radiotherapy department, they need to be compliant with the radioactive waste management rules, and the agency for its authorization is Atomic Energy Regulatory Board. It is not the Pollution Control Board. We should always remember that. And now this is the radioactive waste storage room, which I'm sure all the hospitals, the bigger hospitals which have the nuclear medicine department and the radiotherapy department, they need to have a radioactive waste storage room in their facility. And this you can see that even the sharp containers, they are surrounded by the lead bricks in the radiotherapy department or the nuclear medicine department. And one message I would like to give is the nuclear medicine department, it mainly generates has unsealed sources, whereas the radiotherapy department, it has sealed sources. So the majority of the hazardous waste which is generated is in the nuclear medicine department. And so we have other waste also, like we have the e-waste, and e-waste is covered under the extended producer responsibility. And what does that mean? It means that like e-waste, you are having computers and the automated equipments like the ultrasound machines, the Bactilert system, the midget, they have their e-waste or the computer system around. So that needs to be returned back to its manufacturer. That is by extended producer responsibility. Okay, then these are the radioactive waste storage room and the radioactive drug dispersal room, which has fume hood also, as you can see in the slides. And there are other waste also. So now after covering the hazardous waste, the e-waste, I will be covering the biomedical waste. Since India is signatory to so many international documents like the Stockholm Convention, which was signed in 2006, Araras Convention, which was again signed in 1998, that is for the hazardous waste. So that's why the important implications for the frequent change in amendments and revision in the guidelines. If you look at the biomedical waste, the original rules, they came in 1998. This is the radioactive waste storage room, which I have shown with the lead containers. And e-waste, again, I have this thing that it is covered under extended producer responsibility. That means the, I think my slides and the voice lag is there, but I'll just show whatever slides are coming. And then we have the plastic waste management rules. which came out in January, that is showing that the microns of the biomedical waste disposal biohazard bags, they need to be of 120 microns with the end of 2022. Whereas the last revision in the plastic waste management rules, they mentioned it to be 75 microns. I think most of the hospitals, and in fact the government portal, that is GEM, they have upgraded from 50 microns to 75 microns. But by this year end, we will be having 120 microns. And this is the plastic waste management rules. So, and we are all aware of what are the hazards of unsafe biomedical waste management, apart from the infectious diseases like the HIV or the hepatitis B virus or the hepatitis C virus or TTV. We have the other hazards like the chronic heart and lung diseases because of the incineration ash. We have the asthma, heart attacks, and exposure to radiation, fires, cancers, and malformation, and endocrinal disruption, and air and land and water pollution, not only for this generation, but for next 10 generations, maybe. Of course, it has its own, important implications for litigations if you violate the rules. And the recent topic which has come up is antimicrobial resistance. Antibiotic residues, they are reported in wastewater, groundwater, surface water, hospital effluent, and the pharma industry effluents. And antibiotic resistance in the environment is also reported. And recently we saw Gazette notification for restriction of use of gentamicin, especially for farm animals. And that we have seen. And there was Gazette notification also because antimicrobial residues, they were found in the major Indian rivers like Krishna, then in Ganges, and even in the hills, which are supposed to be, these are the major Indian rivers which were polluted with the antimicrobial residues. And recently we saw Yamuna, there were so many newspaper reports on river Yamuna and the antibiotic residues, and even our hills like Solan and all, they are also having antimicrobial. In fact, I would say that liquid waste management is deficient in Southeast Asia, barring few countries. And so you need to have the environment safe purchase of the pharmaceutical. This is the Gazette notification I was talking about the restriction in the use of gentamicin in agriculture and farm animals. So all the hospitals, especially the hospitals which are more than 100 bedded, which have ETP, STPs, which have rainwater harvesting system, apart from the biomedical waste management committee or the hospital infection committee, you need to have the environment monitoring group, which takes care of the effluent treatment plants of your hospital, water cess, and rainwater harvesting system, herbal garden, water ATMs, etc. Because not everything can be looked after by a microbiologist, and usually this kind of environment related parameters are taken care of by the PWD or the engineering section of the hospital. And so this is an important document, that is consent to operate, that is with the engineering section, and we have the biomedical waste authorization. This particular important document is linked with the NMC registration if you're affiliated with any university, medical college, or the nursing college also. And for MD and the MCH, MS degrees also, DM degrees, because this is the biomedical waste authorization. And biomedical waste management is an important commitment of Government of India. under the flagship campaign of Swachh Bharat, and as a result of which we are having repeated inspections from Ministry of Environment. Us being the nodal center for Ministry of Environment, we have repeated inspection by the State Pollution Control Board, Ministry of Health, even the National Green Tribunal. And if you are from the state government, you will be having inspection from your respective State Pollution Control Board. And waste management is an important thematic area in Kayakalp assessment, NABH, NABL. And this is an important document from the Chief Secretary of Government of India to the State Secretary to maintain the biomedical waste management during COVID. And even in standard precautions, hand hygiene, respiratory etiquettes, safe injection practices, cleaning and disinfection, safe handling of the patient care equipment, environmental cleaning, and soil linens. The biomedical waste management comes last, but an important thematic point. And because of that, the urgent interventions were done when the biomedical waste management rules were framed. Focus was done on the training, the health checkup, immunization, inspection, equipment records. But there were certain shortcomings. The 10% sodium hypochlorite, which was a typographical error that needed to be corrected, non-availability of the PVC-free blood bags, the barcoding. Not all states could implement. Very few cities, I would say at that time, only metros. Pre-treatment was recommended for laboratory waste, microbiology, biochemistry, or pathology waste, research labs, and there was accountability on stakeholders. But since the rules had important shortcomings, there were certain gray areas, they required amendments. And the rollback of sodium hypochlorite from 10 to 1 to 2% in 2018, cardboard boxes, either blue plastic box or the cardboard boxes could be used, both could be used. In situ pre-treatment by the WHO Blue Book, deadline for phasing out the chlorinated plastic bags. That was for biomedical waste disposal. The non-chlorinated bags need to be used. The PVC blood bags were allowed. The barcoding, the guidelines came up from CPCB, and ETP, STP became mandatory. And because to achieve the ultimate aim of green and clean hospital under Swachh Bharat. And then came the amendment in Biomedical Waste Management Rules 2019, which was specific to the bedded healthcare facility to maintain and update the register. This was that documentation was made mandatory, whether in registers or forms, both are allowed. Website, the posting of the biomedical waste monthly and the annual report became mandatory. And our hospital is an important stakeholder in a Ministry of Environment, a central monitoring committee to review the biomedical waste management rules and implementation of the guidelines. And there are certain international documents also which will help you in maintaining the not all things can be documented in the biomedical waste management rules. So you can follow this international literature, and we have the national guidelines for infection prevention and control, where our hospital has contributed a chapter on biomedical waste. Then again, the CPCB guidelines, which give at length what needs to be done, how should be the common waste site be, and what PPE will go where. I will be covering that in detail. And then these are the CPCB guidelines for COVID-19 waste. We had so many of them, so many revisions, because as the CDC was more clear about the category of the COVID-19 virus, the revisions were done, and the most recent being of April 2022. And prior to that, it was in February 2021. That was the immunization waste guidelines by CPCB, keeping in mind the massive and the mammoth efforts for Government of India for COVID vaccination. And this is the recent one, which again focuses on the laboratory waste. That is the 26th of April, 2022. Laboratory waste like the TrueNat cartridges, they need to be pre-treated. The rapid antigen test kits, again pre-treated. And then the Gene Expert chips or cartridges, again pre-treated and disposed as red category waste. And then they have important aspects on home care waste disposal as well. And so accordingly, you have to update your policy of the hospital when these guidelines get updated. And simultaneously, you have to take into account the the policy of your hospital or NABH policy. You have to upgrade depending upon the guidelines. And the IEC material also you need to upgrade as per the if it is of COVID waste, you need to upgrade that on COVID waste. If it is on rules, and like when the COVID came up, we needed to upgrade that because there was a lot of mixing of the solid waste, like any leftover apple by the COVID-19 patient or Bisleri bottle, anything and everything touched by the COVID-19 patient was getting dumped as biomedical waste, which is absolutely wrong because COVID-19 is not a category A virus, and that compromise the already existing waste management, already compromised biomedical waste management system in the country. The waste became 5 times. So no solid waste article from the COVID-19 patient need to be dumped in the biomedical waste hazard bags. Remember that. And so these are the IC material we had specifically pasted in the COVID wards. And then that segregation is done at source, and there is an intramural transport of biomedical waste in these color-coded trolleys and to the common waste site where the waste is barcoded. And this is normally the policy of all the hospital where the common biomedical waste management facility is within 75 kilometers, and the truck of the common facility operator comes and picks it up. Only the pre-treatment is done at the hospital or the lab level. Rest treatment and even the recycling, if any, it's done by the common facility operator. You can have your institutional setup on biomedical waste management. Your hospital director or the medical superintendent, who is the occupier of your hospital, is the chairperson of such committee. And plus you need to have, if your hospital is big, especially more than 100 bedded hospital, you need to have an environment group too for monitoring the environmental parameters and the environmental equipments and devices like the effluent treatment plant, the systems like rainwater harvesting system. And these are the constituents or the committee member of the biomedical waste management team. Apart from the senior officers, additional MS, officer in charge, you need to have sisters also into your team, the nodal officers, departmental nodal officers, the nursing superintendent, the sanitary supervisor, safety officer, quality officer, the engineering section, the store in charges, general medical and equipment store in charges, the administrator, representing especially DDA or the administrative officer. And the role of this committee is to establish policies on biomedical waste management, focusing on system capacity, resources, and processes. And because it's very important to document and attach these 6 monthly meetings. We are having every month we have a biomedical waste management meeting because our is one of the largest tertiary care centers under central government hospital like AIMS. We are close to 2873 bed. So we have monthly meetings, that is the subcommittee meetings, and we have the annual, we have, 6 monthly meetings, like 2 in 1 year, which we are attaching the minutes of meetings in our annual report and also posting on the website. And yeah, so now these are the resources, the non-chlorinated PVC-free bags, which are more than equal to 75 microns. With the end of this year, they will increase to 120 microns as per the new plastic waste management rules. Because of the fire safety and the electrical safety issues, the needle syringe hub cutters, they are preferred over the electronic needle destroyers. So you need to phase out the AD syringes, then other, the foot operated bins and bags. And these are all available on GEM. A hospital is their important stakeholder as far as waste management on GEM purchases is concerned. So you could have, these are the processes, segregation, management of sharps, in-house or the intramural transport of biomedical waste, storage and record keeping. How should your common waste site be? Away from the public or the visitors access, room should be roofed, exhaust fan, it should be manned, there should be a weighing machine, barcoding area, and entrance should have a concrete ramp. Now these all specifications, they are written in the CPCB guidelines 2018. So this is the picture. And if you look at the COVID ward, the picture slightly changes because the sanitation worker who has come from the common waste site and the sanitation worker who's posted in the ward, they've done full PPE and maintaining the social distancing norms. The waste is given to the sanitation worker from the common waste site and following the COVID appropriate behavior and following the appropriate PPE, that is full PPE in the COVID wards. And we literally had to construct a new common waste site because our COVID-19 waste volume was huge during the first peaks of COVID wave. And for occupational safety, you need to have the yearly health checkup, and 2 vaccinations are mandatory. That is the hepatitis B vaccination and the tetanus toxoid. And from 2021 onwards, we have the COVID-19 vaccination mandatory for the healthcare workers. You need to have your monthly record for the biomedical waste management and also the COVID-19 waste record also. This is shared daily with the Central Pollution Control Board on the CPCB app. Please maintain, see, even we are hearing stories about monkeypox coming up. These are not category A virus. So maintain the solid waste stream, separate than that of biomedical waste. Don't compromise the already compromised system of waste management. Don't increase the waste 5 times if you mix the solid waste, that is anything and everything from the COVID-19 patient needn't be dumped as biomedical waste. Only the soil tissues and the PPEs used by the COVID-19 patients will be treated as biomedical waste. And training is very, very important because this data we are sharing on real-time basis on our website, and in any assessment inspection they are checked. We are doing departmental wise training, induction staff training, and we have 2 to 3 trainings in lecture theater modes, and the rest of the training are on-site. On-site training we started during COVID times in small batches of 5 to 10, and all healthcare workers, individuals, groups working in college and hospital both. Apart from the healthcare workers, we were training the security staff, ambulance staff, pharmacy account, and other administrative staff. Training was a huge challenge. In fact, the CPWD staff also, and as per the NMC norms, it is included in the foundation course of MBBS also. These were the topics which were covered during trainings, the rules, the guidelines. Even we were taking for the home care waste generation from the COVID-19 patient, demonstration of needle cutter, demonstration of segregation, role plays, the guidelines, and this is the real-time data. Details are shared in the annual report, and take help of these Swachhta Pakhwada activities, the infection control week or the antibiotic or the hand hygiene week, and or the environment day, you could conduct trainings, the poster competition between nurses, nursing students, MBBS students, kits based on the waste management, the competition of best ward, OT and lab. Now, there are certain advantages of individual department training because, waste, it keeps on, new kind of waste keeps on generating every year, and the disposal will not be documented in the rules. So that's the advantage of the departmental training. And there are certain areas in the hospital which have special waste which need attention. The disposal, we are like, there are 1,000 kinds of waste in the bronchoscopy suite or the endoscopic suite or the dialysis. These all things we have to take into account, and we also assess training. These are important publications from a group, and we find the hazardous waste disposal is a huge lacuna. And monitoring we are doing, this is the in-house check, how you monitoring performer, or you can have a 20-page WHO performer. And website also we are posting the details. We have an in-house biomedical waste management app which we have given to our sisters for auditing the hospital, wherein the photographs are clicked and then they are shared that these are the lacunae. This data you need to post on the website of your hospital or the lab. You can have a portal on biomedical waste on the already existing website or portal. This is the annual report. It requires everything, and I'm sure the biomedical waste nodal officers or the microbiologist fills that and submits to the pollution control board. Now these records are very, very important. The quantity, the logbook, the registers, the monitoring records, health checkup, immunization, training, equipment and supplies, whether you have autoclave, microwave or hydroclave or needle cutters, and the accidents. Mind that what all accidents which need to be documented in your annual reports. It's not the needle stick injuries, it is the major accidents are reportable, like the falling of the biomedical waste in a water body or the toppling of the truck. Barcoding is mandatory as per the guidelines, and when we sit in CPCB, we have realized that all states have, each and every state issued guidelines, stickers. So on the direction of the Honorable Supreme Court and NGT, there will be uniform barcode stickers for all the hospitals from Central Pollution Control Board instead of the State Pollution Control Board, to maintain the uniformity. Now, pre-treatment is recommended of microbiological lab and highly infectious waste. And you have non-chlorinated disinfectant, which are usually quite expensive, barring the alcoholic one, the Lysol, which is already being used in TB labs, and lime milk and calcium oxide, non-chlorinated bleach. These are not expensive. Rest others like the quaternary ammonium compounds, Virex, R82, 83, 84, 86, they are expensive. So we restrict ourselves to the alcoholic disinfectants or the phenolic ones. COVID waste. Mind that we should remember that COVID-19 is not a category A, and even the monkeypox, which we are hearing, is not the hemorrhagic fever viruses. It's not a category A viruses. So as per WHO, the soap, ordinary disinfectants like the sodium hypochloride, ethanol, hydrogen peroxide, soap and water, they suffice. And as for the Public Health England, 90 to 95 degrees centigrade for 1 minute with safe work practices and COVID appropriate behavior, it is good enough for waste management in COVID-19 context. And already we have a very robust biomedical waste management rules. So what are the treatment technologies recommended in the rules and guidelines? They suffice. And these are the various guidelines which have come up during COVID time, the most recent being 26th April one. And these are the international guidances or the WASH guidances, that is waste sanitation, hygiene practices, WASH guidelines, then UNDP guidelines, which are available. You can easily Google them. And if you look at what's there in the COVID waste, there is pre-treatment, there is extensive categories of the laboratory waste, and only the used masks, tissues, toiletries by the COVID-19 patients need to be disposed of as yellow. The food articles, remaining food articles, and the Bisleri bottle, they again go as general waste only. And double bagging is mandatory. Labeling is mandatory. Labeling is mandatory because to expedite its disposal at the common facility level. And this is the isolation ward or the nursing station or the patient area, maintaining the social distancing norms, how the waste is being collected in the COVID ward, management of wastewater from healthcare facilities, the recycling of wastewater during the pandemic, especially during the peak time, was discontinued. And everybody, I will not delve into that. The legal actions under Section 5A or 15A, that is imprisonment up to 5 years or the fine up to 1 lakh. I will not go into detail. Everybody knows that. So yellow category, we have organs, tissues, animal uh, body parts, soiled waste like the items contaminated with blood and body fluid like dressing, plaster, expired medicine, again in yellow. The cytotoxic is the only exception where all the disposable used for disposal of the cytotoxic medicine, they go in yellow container or yellow bag with the cytotoxic label. Rest other drugs, they can go in yellow category, which is a different category. It doesn't have yellow biohazard category, but it doesn't have a cytotoxic label. This was done because the cytotoxic drug, even a minute amount of cytotoxic drug left in the syringe can cause secondary neoplasias, and we are a hot spot for cancers, especially Southeast Asia, as far as the world is concerned. And chemical waste, again yellow, the discarded linen, mattress, and whatever is made up of this kind of material, more of linen, polypropylene, PPEs or the masks or the caps will go in yellow. And chemical liquid waste, remember that it's an important neglected area. Discarded samples, aspirates, they are made safe. Pre-treatment with sodium hypochlorite before mixing with other wastewater. As far as the endowasher fluids are concerned, where the OPHA is used, the holding time is of 8 hours. It is neutralized with sodium bisulfite if it is glutaraldehyde, OPHA if it is glycine, and the pH is checked, diluted, and then drained off. And all the samples need pre-treatment, whether your hospital has E2P or not. And this is the pre-treatment being done of the microbiology waste. These are the culture plates, which are again then put in. These are the indicator, chemical indicator tapes with each batch of cycle. And then you have the spore test, which is done with that is with Bacillus stereothermophilicus in case of autoclave, Bacillus atrophius in case of microwave. Remember that the spore test for the autoclave and the microwave are different, and that is once a week. Vertical placement is always better. And so if you look at microbiology waste, microbiology waste doesn't mean that even the vacutainers will be dumped in yellow category, or the swabs, the plastic swabs will be dumped in yellow category, or the toxin assays or the slants will be dumped in yellow category. It means there is pre-treatment if it is log 6, that is culture, broth with a live organism, or the devices used to transfer such organism. Therein, log 6 reduction by autoclaving is required. When you have samples You can do log4 reduction, that is, or you could do autoclaving also, disinfection or autoclaving. And what about vaccine? Again, disinfection suffices. If there is capacity in your waste autoclave, the best practice as per WHO is you can autoclave all. But normally the autoclaves are small in size, the labs are big. Even despite having 2 waste autoclaves, the capacity is full, so slides can be disinfected. What about the serology lab waste? So these are all plastics, so they will be all pre-treated. You can see that even the April 2022 guidelines mention the Gene Expert cartridges, which are these, again plastic, disinfected, and then in their respective red category. ELISA plate, disinfected, and then in their respective red category, not yellow. Mind that. That's a blunder what the laboratories do. I think they did initially in 2016, 17, 18. Then the guidelines came up, things became much clearer. Even these kind of Eppendorf tubes, pre-treatment and red category. Liquid waste, I'll just flip past these slides. I think I've covered in details about the neutralizing agent. Remember that. For your chemicals, you need to have the material safety data sheet. Their disposal is clearly given on that. What is the neutralizer? And when you're making the specifications of a particular chemical, ask for the material safety data sheets and ask for the neutralizer too. So now we see, like, most of the laboratory waste comes in the red category for pre-treatment. You can either have the transparent autoclavable bags, autoclave them and then put in red bag, or you can have red autoclavable bags. Both the practices are allowed and are as per the WHO principle. What about your rapid card? Again, pre-treatment by disinfection. It is disinfection or by autoclaving, and then in the red category. Okay, then what about those safety syringes? Safety syringes where the needle completely goes inside, that again goes into red category. That was an important amendment in the 2022 CPCB guidelines. Okay, then what about these waste sharps? Remember that not all sharps can be mutilated. They are lumbar puncture needle. You cannot mutilate them. Only the simple needle syringes, the syringes which have the 22 to 26 gauge needles, they can be mutilated. The rest, the lumbar puncture needle or the blades, they cannot be mutilated. And dispose them as it is. Blue, all the microscope slides, cover slips, glass chambers, they can be disinfected and then in the respective category of blue. Standards are already documented. I will not cover that. These categories I have taken in detail. Now, what about the plastic PPE, the goggles or the PPE, which is of plastic used in the COVID-19 wards, nitrile, latex, or the heavy duty gloves? They will all go in red. Face shields also in red. Then what about the shoe covers? Shoe covers, because of thin, non-recyclable plastics, they will go in yellow. Blue is for the glass, white is for the sharps. And these are the effluent treatment plant which are looked after by the engineering section. The consent to operate and establish is again looked up by the engineering section. These are the effluent treatment reports, which at least should be done twice in a year. And the CPCB guidelines mandate the use of online monitoring system. So if you have the online monitoring system installed, then the effluent need not be tested because everything is recorded there itself. I'll be showing, I'll see if I have a picture. What about the COVID vaccination center? The waste management is as earlier. There are guidelines on the vaccination waste, keeping in mind the mammoth effect efforts of Government of India. We have yellow, again, the category is same, cotton swabs used in immunization, cut, the hub of the syringe, sharps, the needles, they go as sharps, white. And then what about the vaccine vial? The vaccine vial, after 48 hours, when the AEFI documentation is done, after 48 hours, they can be pre-treated by disinfection or autoclaving. Both are allowed, and after that, in their respective. So that is my slide for the vaccination waste. And this is an important WHO document, Global Analysis of Healthcare Waste in the Context of COVID-19. Our hospital is an important part. And biomedical waste management is an important thematic area in KIACL, in NABH, in the NMC, and it has its own important challenges. But if a large tertiary care can do, so I think anybody can do. And so points to ponder. We have spoken about the biomedical waste management rules and their implementation, what's there in the guidelines. What are the status of implementation of other rules? The other rules are not even implemented 10%, but they have important implication for biomedical waste management. COVID-19 was an important, was the eye-opener, I would say that, because a lot of solid waste was being dumped in biomedical waste because the rules were not implemented across the country. And slowly and steadily, government is looking in on the implementation of other rules because they have important ramifications with biomedical waste management rules, like the e-waste rules are not implemented. And for biomedical waste management, more focus is on training, health checkup, immunization, inspection, equipment, records. Hospitals have done the urgent intervention, but with the pandemic coming and one like monkeypox just knocking the door, even if we have done the urgent interventions in terms of system capacity, greater resources and processes, we need to be on alert every time, as we had seen during COVID-19. Amendment and guidelines. Why you see every year there is amendment, there is gazette notification or some guideline coming up on waste disposal, because since India is signatory to Stockholm Convention, we need to decrease the yellow category waste. When our recyclers of the red category increase, you will find each year we are decreasing the yellow category and increasing the red category. Not all sharps can be mutilated. Combination of sharps and plastic as sharp waste, and return back to manufacturer, that is extended producer responsibility for the e-waste and the combination instruments. Whatever is not documented rules, follow the international literature. We have an important lacuna in India, that is common facility operators. They are not enough in number. And by conducting the state-wise training with the Central Pollution Control Board, we are working on that. And because the ultimate aim is green and clean hospitals under Swachh Bharat.